Welcome to Q&A with Prof. A. This is the Bato kay Doc Bato educational series for medical students and residents. Our question for today is, Prof. A, what is enuresis or bedwetting? Enuresis is intermittent incontinence exclusively during sleeping times, occurring at least one episode per month in at least 3 months duration in apparently normal and healthy children older than 5 years old. According to the International Children's Continence Society definition of terms, enuresis is a storage symptom, together with frequency, which is defined as more than 4 to 7 times voiding during daytime, incontinence, which is uncontrollable leakage, of which enuresis is one, urgency, which is a sudden unexpected experience of an immediate and compelling need to void, and nocturia, which is waking up during the night without leakage. This is different from your voiding symptoms. Voiding symptoms are hesitancy, which is difficulty in initiating voiding, intermittency, several stop and start spurts during micturition, and dysuria, which is burning or discomfort during micturition. Let's review the physiology of micturition. Always remember the letter S, which stands for storage, and the sympathetic nervous system, while the letter P stands for P, which is your parasympathetic nervous system. Your sympathetic nervous system occurs in your T12 spinal cord level, and your physical exam finding that we do is your cremasteric reflex or your hip flexion or patellar tendon reflex. While for your parasympathetic, which is occurring from your S2 to S4, is your bulbocavernosus reflex or anal wink. Let's review your micturition milestones then. At 1.5 years of age, the infant knows that he is wet. At 2 years, he obtains diurnal control. At 3 years, he obtains nocturnal control. While 5 to 7 years, they gain full bladder control, such that any disorder occurring more than 5 years of age may be abnormal. Why do children wet the bed? The bladder muscle, what we call detrusor, develops slowly than usual, or the bladder holds a smaller than normal amount of urine, or the child is making lots of urine, which we call nocturnal polyuria, or the parents or siblings have enuresis, or they may have altered sleeping mechanism. What are the common comorbidities associated with enuresis? The most common is constipation, followed by urinary tract infection, then your obstructive sleep apnea, then your overactive bladder, and ADHD. Differential diagnosis for incontinences in apparently normal children, such as enuresis. It is associated with sleeping upper airway disorders, ADHD, and obesity. It is self-limiting, unlike your low urinary tract dysfunction, which presents with daytime non-neurogenic voiding disorders, which we call functional urinary incontinence. It is also associated with sleeping upper airway disorders and ADHD and obesity, but it is persistent for more than 3 years. There are two types of enuresis. Your monosymptomatic nocturnal enuresis, or MNE, which is enuresis in children without any other lower urinary tract symptoms. They are apparently normal and healthy. They need no further investigations, but they may have 6 months dryness before the symptoms occur. While your non-monosymptomatic nocturnal enuresis, there are daytime bladder symptoms with incontinence, urgency, weak stream, leakage, holding maneuvers, voiding less than 4 or more than 7 times a day. They have abnormal physical exam, and they need contrast urodynamic testing. The only diagnostic test that we can use for enuresis is your plain and simple urinalysis. And I will give you a tip how to interpret it. Before you decide on what to do, always first look at the specific gravity. If it's dilute or too concentrated, discard the sample and get another one. Then, check for protein and blood. If both are there, then 80 to 90% you're sure your patient might have glomerulonephritis. Then check for glucose to document diabetes mellitus or glucosuria. The general principles of management for enuresis consist of 3 aspects. Number 1 is education and advice. Always tell the parents and the child that it is self-limiting. It will go away, so don't worry. And bedwetting is not the child's fault, so don't reprimand them. Always encourage the child to urinate regularly during the day and just before bedtime. Tell them to avoid sugary and caffeine-containing drinks, especially in the evening. Tell them to drink most fluids in the morning and early afternoon and only 20% of the total fluid intake at night. And tell them not to tease or allow siblings to tease the child who has wet the bed. The second aspect are bed alarms. This is the first line treatment for enuresis. However, it requires motivation for the child and it may need parents to wake the child up to pee. But it can be used even with learning or hearing disability. The third aspect of management for enuresis is pharmacologic. We use the drug desmopressin. This is used for patients who are resistant to bed alarm therapy. However, it is just quick fix and with short-term improvement, but it's ideal for patients with nocturnal polyuria. However, it needs titration. So to summarize, enuresis is intermittent incontinence, not persistent, exclusively during sleeping times, occurring at least one episode per month in at least 3 months duration in apparently normal and healthy children older than 5 years old. For more high-yield concepts in pediatric nephrology, don't forget to click the subscribe button.